studio with us today, we have an amazing guest, Dr. Atiya Mosam. She's a public health physician and director of Mayibuye Health, which is a public health technical advisory firm. With a fellowship from the College of Public Health Medicine, as well as a Master's of Public Health and a Master's of Medicine. Atiya has 15 years experience in health system strengthening initiatives, from national policy development to health management and implementation of interventions. Atiya is an honorary lecturer at the University of the Witwatersrand School of Public Health. She is also an IAP Young Physician Leaders alumnus who serves on many committees, including the WHO Roadmap for the Public Health and Emergency Workforce, and a council member of the College of Public Health Medicine. Welcome, Dr. Atiya Mosam. As an expert, as a professional working in the space, can you paint us a picture of the current state of our healthcare system in South Africa?
Sure. So, because we are talking about the NHI Act and the rationale around it, I'm going to talk around financing, because at the end of the day, the NHI Act is primarily a financing act. Okay. Obviously, there are some changes to service delivery that will need to happen, to information systems, etc. But it's primarily a financing act. So I'm going to go through the financing and then talk a little bit about, the quality of care that we get currently in the system, and then maybe some of the challenges around it.
Sure.
So in terms of financing, we look at it in two ways. We look at where we get our money from, and then what do we do with that money. So if you've read any of the NHI material, you will see that our government says that they spend between 8 to 9% of our GDP on health. That is quite a substantial amount if you compare to other upper middle income countries, to even some European countries. And so it sounds really great. But where we are falling short is that if you look at where that money is sitting or how it is used, is where the challenge lies. So the challenge is then in how that money is disaggregated. So we've got, as you well know, money that comes from Treasury as part of budget for the health department, and that's about 50% of that 8 to 9% of the GDP. And then we've got the other 50% that sits in the private sector, coming through medical aids, or if you pay, for example, Dis-Chem directly or a GP. Now, the issue is that the first 50% from the public sector looks after 85% of the population. And the other 50% is looking after 10 to 15% of the population. So that's a massive inequity. I mean, you are spending about 5 times more in the private sector. So that's the one inequity that the Act is trying to address. Then if we look a little bit further in terms of how we spend that money. So in the public sector, we spend money on obviously salaries, and then our facilities, etc., through budgets. And in the private sector, it is spent paying directly to hospitals. It's called fee for service. So you pay per service. You pay the doctor separately, you pay the hospital separately. The challenge is that whether in the public sector, the way it's set up at the moment, or the private sector, there isn't really any incentive to be efficient, so to do as much as you can for as little money as possible, but still keep quality of care, because we obviously don't want to deliver bad quality of care. Nor is there an incentive to do things well, because regardless of what you do, you're still getting paid. Right? So you're still getting a salary if you're in the public sector. You're still getting the money from the medical aid if you're in the private sector. And so that is what the challenge is at the moment. It's where the money is lying, and then how do we spend it efficiently. And then we look at sort of the next level is like, are we getting bang for our buck? We're spending that amount of money. Are we getting good quality outcomes? Now, when we look at quality of care, we if I had to ask you now, if you thought of quality of care, you'd probably tell me, oh, it's a nice facility. And
absolutely.
right?
Clean sheets.
Clean sheets, and they bring you nice food, and that's undeniably important. No one wants to be sick and in a place that's falling apart and dirty, etc. But there's other aspects of quality of care. There's where the people are have a good attitude towards you, right? Whether you wait forever in a line or to see a doctor or to get a surgery done, whether you actually get better, or if they can't cure you, at least make you make the condition something that you can live with in a way that is manageable for you, and also that they don't do things to you that are not necessary. So those are all of the things that we have to think about when we think, are we getting good quality of care? So anyone who's read the newspaper will probably know, in the public sector, we've seen the audit reports, we've seen inquiries, and we know we're not doing well on those. The issue is that we also have a false perception that because we pay a lot of money in the private sector, that the private sector is doing better. And the thing is, we actually don't know.
Wow.
We haven't been following the outcomes of the private sector to say, if they spend this amount of money on this procedure, that outcome is what we get out of it, good or bad. So yes, they have very nice facilities, but in terms of actual health, are we getting, for that 5 times more that they're spending, are we getting good health care? So that's primarily where the NHI is aiming to kind of try and sort the health system out. But there are other challenges. There's challenges, for example, in terms of accountability. So anyone who's lived in South Africa will know that's an issue across the board.
Across the board,
right?
Absolutely. Yeah.
So we don't have accountability in terms of our leadership. We don't have accountability in terms of whether people do something incorrectly when they are seeing patients. We don't have really strong accountability there. In the private sector, again, maybe like accountability for financial risk, etc., is better because there's much more oversight, because they are all profit-making entities. But clinical accountability, which is, looking at what your healthcare workers are doing, is not as strong because they are all somewhat self-employed, except for maybe the nurses that work in facilities. There's no real accountability in terms of the money that is spent. No one is looking at the costs and figuring out, well, was that a rational use of money? So that's the one issue, is around the accountability of both the public and the private sectors, and regulation around it. And then obviously corruption, we're probably going to get to that, right?
We will.
So, corruption is that we know this. There's been tender fraud, there have been goods that have been stolen, and then the small things that people don't see as corruption, but is actually corruption when you have a job and you don't go to it, or you are employed by the public sector but you sit in private practice the entire day. So those are some of the issues around governance and accountability. We have HR imbalances. So I'm sure it's quite evident that even though we have more human resources than other African countries, we still have that imbalance. So we've got, I think, if I'm not mistaken, we've got something like 7 specialists per 100,000 people in the public sector, compared to 69 specialists per 100,000 people in the private sector.
Wow.
So it's a huge imbalance. And then we've got real imbalances between rural and urban areas or different provinces. So like Limpopo will have, I think it's around 15 per 100,000, and then Western Cape has about 29. So we've got that we have to deal with, and it's not easy because people want to obviously do what's best for their lives as well, right? You can't force someone to go work in Limpopo.
True.
So how do you make sure that Limpopo then gets the resources? So we have those imbalances, and then to the point around the quality of care, and staff attitudes. When you have so few staff, people get burnt out. They are, frustrated by the system. Then that is when they make mistakes, or they, don't treat people well. There's a lot of antagonism, so there's that we also have to deal with. And in the private sector, there's an oversupply. So there's a lot of competition. People may do untoward things, unnecessary tests, because now they're trying to earn money. And then the final thing I think that's important to note is actually around service delivery. So we've got a range of hospitals, clinics. We've got in the private sector we've got general practitioners and specialists, and then we've got hospitals. So we've got a very broad mix of arrangements in the public and private sector. But again, where the challenges come is that we don't really have sort of coordinated care. So that you get duplication again, right? Somebody may go to their GP and then run out of money, and so then they get sent to the public sector, and then the public sector may do the same.
The whole process starts again. Yes,
exactly. So we've got that duplication. We don't focus on preventing diseases or promoting health and keeping people healthy or detecting diseases early. So people then end up coming to us really late stage. It's very costly. Outcomes are really bad, and we don't work with other clinicians or other people within the health system really well, whether it's another facility or another provider, etc. So those are some of the gaps in service delivery that is trying to be addressed also within the NHI Act, to make sure that we see people holistically, we see them early, we make sure that they get the care that they need, because we have the sort of these gaps in terms of how we deliver services at the moment.
Absolutely. Thank you so much for such an in-depth picture. And unfortunately, it's not a very positive one. But this is why I want to just, starting from the top, what is the NHI? And I'm so grateful that you mentioned inequality and the imbalances, because it's also about how is NHI then going to try and address these imbalances and address the inequality that exists within the public and the private healthcare, and also the imbalances within them. So what is it? What is the NHI? If I've never heard of it before, what is the easy way to help us understand what it is and how it is striving to address these challenges?
Sure. So the NHI, as I say, the Act is primarily about financing. So what is the aim is to produce or establish an NHI fund. So if you think of it, you can think of it like a Discovery Health fund, but for the entire country.
The country,
right?
Okay.
So it is an insurer, basically, that is going to get money from somewhere. So currently people pay, for example, Discovery or Bonitas or whoever it is, and then they pay for healthcare on their behalf. NHI wants to do something very similar, but just the source of money is different. Okay. So they will take money from general tax, which is what we currently have already, that first pot, and then shift also money from the second pot, which is what is currently circulating in the private sector. And instead of you or your employer paying Discovery, you will pay into the NHI fund.
Okay.
Right? So it's basically bringing all of that into one pot.
One pot.
Right? The aim of this is towards something called universal health coverage, which means everyone has access to the same healthcare, the healthcare that they need, regardless of their income, and they are not put under any financial distress to be able to get it. So right now you can, as we said, potentially get good quality care in the private sector, but you don't know how much you're going to have to pay for it. If Discovery, for example, will pay all of it, or you're going to have to pay some out of pocket. The point is to make sure that everyone has access to that same good quality care, regardless of your means. So in terms of, as I said, the money is there's going to be a shift, firstly, in where that money comes from, and then a shift also in how we pay people. So they will be moving away from paying for each thing. So paying the doctor for one consultation and paying the hospital for that, whatever it is that they are seeing you for. They're going to look at ways that they pay for outcomes. So they pay so that they get good outcomes. So they incentivize you to do better in terms of health. That's quite a very complicated financing discussion. But I will say that I think one of the challenges has been that a lot of people don't understand how this financing is going to change. And so there is a lot of anxiety around it because it changes the way your livelihood is affected. So that's primarily what the NHI is going to do. In terms of inequity and inequality, currently, if you look at it, in the public sector, taxation, we all pay taxes, and in many ways, those that have the means are subsidizing those that don't have the means, because you are paying your taxes according to how much you earn. And by virtue of that, you are also sort of the healthy people subsidizing people who need care, right? In the private sector, that latter one, where the healthy are subsidizing the sick through medical aid, is also present, because you don't always use your medical aid. You pay it every month, but you may not use it, right? So that money is being used to help other people who need it. But because that pot is so concentrated on those who only can pay, there is no subsidization from rich people to poor people in the private sector. It's only those who have the means subsidizing other people who have the means. And so the NHI is aiming to get both of those, to get the cross-subsidization from not only healthy people to sick people, but cross-subsidization from those who have the means to those who don't have the means. And that's where the attempt to address inequity lies.
Okay. The concern for me, of course, as soon as the focus is financial, is corruption and mismanagement.
Yeah.
So are there any measures put in place to address corruption and mismanagement in the implementation of the NHI?
So that has, and you're not the only one, that has come out very strongly in the submissions when the bill was going through its legal processes, in the court cases that are underway, because as a country we have a history of state capture. As I've said to you, we've had tender fraud. We've had instances like the Mrs. Diokran who was the chief director for finance in Gauteng Department of Health, if I'm not mistaken, who was assassinated for uncovering fraud. We've had those instances of large scale corruption and fraud. So it is very, very it is a very, very big concern for many people in this country. You don't have to be working in the National Department of Health for you to be concerned about it. Having said that, it's not that the department is unaware of this risk, and they are designing, as far as I know, towards it. So at the moment there is within the National Health Insurance branch, there is a sort of sub-directorate that is looking at fraud and risk, all the way from where the people will, for example, you're going to have like an ID card that will be like your medical aid card. How do you prevent fraud on the ground, people using other people's cards, to how do you ensure that people are not claiming for, a provider is not claiming for somebody that they didn't see, or how do you ensure that people are ordering supplies that they need. So they have to look at every aspect of that system, that entire flow. They have to look at it from when a patient gets to a provider, is seen, a claim is made, all of that, they have to look at it and understand where the risks are and try and mitigate against it. And then obviously, if you can create any system and people find a way around the system. So in the event that that happens, what are the penalties? Legal implications for whoever is involved in this type of activity. So it's not that the NHI is not being designed accordingly, but there are these real-time risks, and it's something that they're going to have to mitigate as they build. The other large issue that comes into place, and that's been a big point of contention, is the concentration of power within the minister. So if you look at the Act, the minister gets to appoint a lot of committees, etc. Even though it will go through cabinet, there will be processes, and so people are quite concerned, especially from a state capture point of view. If you concentrate too much power in one position, you can end up in situations where you do have fraudulent activity. So there has been push towards having stronger external oversight, stronger regulation, ensuring that, for example, civil society can hold the NHI fund accountable for whatever is. So there is going to be a lot of, I think, there currently are a lot of legal battles around it. It's going to be a long road of ensuring that we design the system and that we have all of the checks and balances in place to make sure that we do not allow the system to be corrupted or put under any risk.
With the financing so is the NHI basically going to replace medical aid in the private sector? Is that what we're saying?
So the long-term goal in any health system is that you want your country to look after its population, right? So that is the long-term goal. The NHI does aim to do that and has said that medical aids will provide services that the NHI is not providing. What actually that is remains to be seen. So they have given some examples, like for example, plastic surgery not for medical reasons, like if you just wanted to look better, that they don't feel is a good use of citizen money basically, or the country's money. But what will probably happen is that we will not have, and already we know that we have an issue with financing. So we can't, the people who are administering the NHI can't wake up tomorrow and go, great, we are paying for all of this and there will be no more medical aid, because we don't have the money to do that. So it will be a phased implementation. So they will say, right, so as a country, and they've said they've already started working on this, certain things are priorities. So for example, maternal and child health, huge priority. So they've started with that. They will start bringing those services into the NHI, and then as they bring them into the NHI, they'll be removed from the medical aids. So slowly, then you'll add other populations, other diseases. So slowly, as you increase the basket of services that the NHI can deliver, you will decrease what the medical aids will be able to do. So that is the aim. Again, it's quite contested. So, and we'll have to work towards that solution. So it may get to a point where the government will actually say, we can't afford everything. So there may still be a role for the medical aids. At the end of the day, it's going to be sort of a progressive realization of these services. It won't be immediately we can deliver everything for everybody, all under the NHI fund.
Would it be fair to assume that some of the pushback is from the private sector itself, in terms of the economic risks that they maybe see for themselves? So what are the economic benefits if NHI succeeds and we do this phased approach? What are we looking at in terms of the economy of the country? How would it affect that in any way?
So yeah, so just to answer the first part, there has been pushback because, like I said, it's uncertain. People don't know what this will look like for them. Medical aids do employ a lot of people, so if they contract, what will happen to all of those people? For doctors who deliver services, they don't know, will they have to take a massive decrease in their salaries because now they're out of the private sector where they're earning excessively well to state level salaries, etc. So there is a lot of that economic anxiety around it, and there isn't really any way to tell, right? Because we're still designing the system, so we can't say to people, no, you'll be fine. Everyone has to come along on this journey with us. In terms of the benefits, so health and like the economic activity of a country are so intertwined. If you've got a healthy population, they can work, right? And then they can produce. That's basically it, right? So economically, we can look after our population. We will be in a better space to drive our economic activity. But then there's obviously benefits for the sector in itself. So like I said, if we are all under one administrator, then there is the benefit of having oversight, so you don't have that duplication. So you can track a patient and go, hold on, this patient was at this GP, why are they at this GP now? And ensure that there isn't that duplication of services. When you are such a large purchaser of services, you have efficiencies because you can buy things, right? You can buy, if you are buying 100,000 Panados and someone else is buying 5 million Panados, they're going to get it cheaper, right? So there's those economic efficiencies that the country can introduce. And also if there is better control of cost or oversight of costs. Like I said, right now in the private sector, you can go to one doctor and he'll say the surgery will cost you 75,000 Rand, and another doctor will say, no, actually based on my own self-assessment of my worth, think that I must charge you 100,000 Rand. You don't really have, as a patient, any agency in that. You kind of have to trust your doctor that they are doing the right thing and charging you accordingly, right? It's not like buying a cell phone where you can go and go, okay, so a Samsung has so many megapixel camera and I can go onto Facebook. And then, Huawei has also this many, and you can make some sort of decision around it. With healthcare, you can't. You don't really know the outcome. And you've got to trust the person. And so some of that type of inefficiency where we are leaving it to providers to decide, what things should cost is where we could potentially recoup some of the benefits.
Okay. That definitely touched on a question that I was about to ask in terms of how can the NHI save us money, essentially in its implementation. But before we kind of move there, there's an interest that I have in terms of the risk of these two pots coming together. So the taxpayer as well as the private sector and healthcare, if it's not enough, I don't know, for what the NHI wants to implement. I mean, an example of a country that implemented community-based insurance is Rwanda. But their risk is that 90% of it is being funded by foreign investment. So do we run that risk as South Africa that we might need to lean on foreign investment? And if we do, what does that mean, for us with the NHI?
So that's a fair point. And I think we've all seen in this past 5 months the implications of relying heavily on foreign investment with the removal of US aid, right?
Absolutely.
We are in many ways in a better situation than many countries because we are not heavily reliant. Our government still funds a lot of our healthcare. So it is not a model that we can move towards. We should not be utilizing foreign investment for direct service delivery. We can use it to do broad technical thinking and, innovation and all of that. But like to actually see patients, we should not be using, foreign investment. The sustainability of the NHI fund is, again, a contentious issue because, as we said, the one pot is coming from taxation. With this recent VAT going up, going down discussion, that's also shown us we are at a point economically where we cannot stress our tax base anymore. So we are limited in how much we can get from taxation. Similarly, the funding that's going to come from what they called mandatory prepayment, which is the equivalent of paying, your medical aid fees, depends on you being employed. And in a country where we don't have that much of formal employment, that is a risk because you can then only collect it from those people. It's not like you can go to every vendor standing on the street corners and, collect money from them. You can only collect it through formal processes. And if our economy doesn't pick up and if our unemployment rate doesn't decrease, then that base of people is going to be very small as well. So that is a big concern in terms of the sustainability of the NHI, and that's why I said that there's going to be this phased implementation. They can't. I know a lot of people last year when President Ramaphosa signed it in, people thought they're going to wake up the next day and there's going to be no
just
medical
free healthcare.
And but we can't. It's not. It's not sustainable. We're going to have to, and it's going to take many years. I know. We've got ambitions in the act about this must happen in these many years and stuff, but the reality is you're shifting an entire system. You're not just shifting how things are funded and paid for, you are shifting how people deliver services, how they buy goods, who they report to, how they recruit. It's going to take a long time to get us all on the same page.
It just constantly seems like it's a long road to freedom.
It is a long road to freedom.
Bit of a long walk, but I'm learning so much. If we can shift from the finances, because I want to look at something that you did touch on, which was the human resources themselves, and the thinking or the murmurs that there's fear among the doctors in terms of security of income and the level of salaries, the security of jobs, and all of this due to the NHI, the changes that the NHI is going to bring. What are there fears? And are there signs that people are acting on those fears? Our healthcare professionals are acting on those fears in any way?
So this is interesting because I think it's not only the NHI at the moment that is impacting the anxiety in the healthcare workforce, especially the doctors. So you would have probably seen in the newspapers at the moment, there is like 800 doctors that are unemployed. And in previous years, like medicine was a, secure career, right? There was no like a doctor is unemployed.
Get a job.
Yes. So there's that, and yesterday in the budget speech they said that they've mobilized funding to be able to employ those doctors. So so there's that anxiety around not having a job when you come out of medical school. And then for the more established doctors, there's this, as you say, this anxiety around what will this mean for my practice. In the public sector, possibly not a lot will change for those doctors because they were salaried anyways, you work in the system. Hopefully, if there's more human resources, better distribution, the working conditions are better for them. So it's hopefully a better system for them. In the private sector, and I'm probably not going to be popular for saying this, but doctors earn excessively well. I can't make a judgment on I can't tell you that they earn 20 times more than the public sector, etc., because we don't really know. I mean, only SARS knows because they report to SARS, but there's no repository of what doctors earn. But they earn excessively well. And the question is going to be, will you be able to meet in the middle between what a public sector salary is and what people are earning in the private sector? And so there is that anxiety around their earnings. Similarly, the new way of thinking around how you deliver services and how you work in teams is something that we don't really learn in medical school. So they don't really teach you how to think of costs and how to do the best for your patient but not waste money. So that is a risk to a lot of doctors who have to now undertake this new model of care where they are going to be reimbursed based on like how good the outcomes are. So there's obviously a lot of anxiety around that, because this is not just I do what I think is best and then the medical aid will pay me for it. So obviously when people don't understand something, that's when you get all of this unrest and people want to leave, etc. I have seen, they quote that, I think, I don't know, there was a study that was in the newspapers that said like a lot of doctors want to leave and they're making intentions to leave. I don't know how much of that is a bit of propaganda to support not having the NHI. But there definitely is anxiety from the medical fraternity around the NHI. I don't think that the government has done a good job of engaging with these stakeholders, because a lot of it has been very antagonistic. Because, for example, the South African Medical Association is taking the government to court around this. So it hasn't been like a let's sit down and discuss kind of, or let's explain, it's been more of this antagonistic relationship. And so I do think that a lot of effort needs to be in place to sort of bring, all your healthcare workers along on this journey, so that they understand the implications for themselves and then can make a more informed decision. Because the reality also is that it's not as easy even working elsewhere. If you go to the likes of like Canada, for example, or Australia, you're still in a salaried position. You're not earning the way our doctors are earning here, and now you've given up your country to go. So it's not an easy transition. So even though people are, thinking about it and stuff, it's not something that they will just tomorrow decide to go, because that doesn't necessarily mean it's going to be all hunky-dory on the other side.
And that is a myth that I'm very glad you busted, because I think that's the thought, that it's always greener on the other side for whatever reason. But it's a bit disappointing that they're not engaging each other on a proper discussion to help healthcare practitioners be comfortable with this shift, because that was going to be my question, is what is our government doing other than saying in a budget that we will, which is what we've been hearing, is we will create jobs, we will create opportunities, but what is actually being done? I mean, an example that comes to mind is the dwindling numbers in nursing, for example. There aren't even a lot of people doing nursing, as a profession. We're not producing them, so we're lining up having nurses who don't really take to patient care. I mean, personally, I've had an experience in a public hospital, and the nurses were not caring. But at the same time, I have a mother who's a nurse who went into this because she absolutely loves people, and she's a retired nurse being asked to come back and work at public hospitals. And I'm trying to understand what's happening, that we're not producing, nurses, we're producing graduates of doctors, and then they don't have work. What is being done, to look at this issue, especially with the lens of the NHI, because we need them. That's the basic line. We need them on board.
So that's a very good point, because especially our public sector is very nurse driven, and more so when you are looking at primary health care, less so obviously in your specialist hospital. And so the nurses really are a huge backbone of the system. And it is concerning that we have these gaps in nursing. And partly it is understandable. As you say, you know, we've obviously got a legacy of nursing being one of the professions under apartheid that, you know, people of color could do. But it's not glamorous. And unless you are someone, and it's not even well remunerated if you compare to, for example, the doctor's salaries. If you compare like nurses' salaries to doctors' salaries, there's quite a huge gap. So you really have to want to be a nurse, to go into nursing. And you really have to want to do it long term. Because, you know, for many of the youth right now, it may just seem like, because we have such high unemployment, it may be like, okay, I'm going to go do nursing and then, you know, find my way into another sector, or you know, teach or do something and not be involved in patient care, because it's a really hard job. Nursing is, you know, and I understand, I don't, what is the word for it? I don't condone the behavior of some of the nurses, but I do understand the immense pressure that they're under, the really bad working. I mean, if you are working in a clinic and you don't have water, or you can't go to the bathroom nicely, you don't have time to eat, those are inhumane conditions. So when people then turn around and treat other people inhumanely, it's not surprising, right? So all of that is, you know, a lot of the reason why people just don't want to go into nursing. And so unless we fix the system to make it feel to people that it is a vocation and they are valued and they are doing valuable work, we're going to go around in this circle of having people come in, realize that it's a terrible job, and then leave. And then we train and we spend money on training for no reason.
For no reason. Hopefully with the NHI coming in, they can actually look at this and provide real solutions. I don't know, from your perspective, are there any that they could, you know, implement in terms of having conversations with healthcare practitioners? Is there anything that the NHI should maybe look at, you know, just from your perspective, to help with this human resource issue?
So, you know, the NHI is at the end of the day, it's just the mechanism to pay for healthcare. All of that work around training and recruitment, etc., lies firstly, obviously, with the National Department of Health, who comes up with our policies, and then the universities, etc., who then train, you know. So they are then responsible for thinking that through. However, the NHI has a responsibility to make sure that the conditions that, you know, are amenable for people to want to stay in healthcare. So again, not, you know, because money is an incentive, so ensuring that they are paid decently, etc. And then the provinces or whoever owns the facilities or runs the facilities has the responsibility to make sure that there's good infrastructure and the working conditions are decent, etc. So everyone has a role in this. You know, it's not just the NHI. The NHI is, yes, aiming to address the inequity and hopefully try and shift money so we can do better with the money. But there's many, many stakeholders that need to come to the table to ensure that our health workforce is looked after.
And that's fair, to have everyone's input, you know, in creating a successful, you know, healthcare for an entire nation. It only makes sense. With this focus on what the NHI can do, if we look at that, you know, what services will the NHI cover, and will there be limitations to the services?
So, I mean, at the moment, if you look at our public sector, technically you're covered for everything, right? You can go for whatever you need in the public sector. Yes, they may not, like I said, to go back to plastic surgery, they may not give you a nose job because you want to look prettier, right? But if you had a medical reason for needing, you know, a nose job, then they would do it, right? So there is, like, for example, plastic surgery in the public sector. So at the moment, the public sector technically services or provide services for any sort of health issue that someone may have. Again, we can't now take away those services. Constitutionally, you can't now remove things that were already in place. But how they're going to shift how those services are reimbursed will be that transition that I was talking about. So we'll start with, okay, from the big basket that the public sector currently provides, which services do we prioritize now? And then we test that in the NHI framework and think, okay, that's running well, remove it from the medical aids. And then add another set of services, test it, remove it from the medical aids. So we will hopefully get to a situation where the NHI covers everything medically necessary and that is efficient. So again, you know, to use, for example, if you are diabetic, the NHI might say, you can, and medical aids do this already, right? They will say to your doctor, under this person's scheme or whatever they pay for, you are allowed to do XYZ interventions, you are allowed to give XYZ medications. The NHI is going to have to do all of that. They're going to have to figure out what is the most cost efficient and good quality medications to give. What are the, you know, sort of, we call them clinical algorithms. So what processes a patient might need to go under, how often do they need to go test their bloods, how often do they need to have their eyes checked. So there's all of that thinking that they're going to have to do. So there may be things medical aids may still be in place for. So if you wanted some really high-tech medication, that now the NHI says, no, it's really out of our, you know, it's not efficient in terms of costing for us to be able to deliver this, then maybe medical aids will be able to pick up that slack. But again, this is going to take a long time, many people to sit and go, what is the best way? And it's a lot of work. If you have to think of all the diseases, you have to think of all the diabetics, then all of the hypertensive. So it's going to take a while for them to get through all of those services and all of those conditions, and then figure out what we can pay for, which is a smart use of our money and will give us good quality healthcare. And then what we have to be realistic and say, well, maybe the private sector still has a role to deliver that.
And in this phased approach, from your perspective, what are some of the logistical challenges that they'll have to deal with within the NHI?
So there's a lot. So, you know, they are basically putting into place systems that you would have seen with medical aids already. So information systems, right? If you go to a hospital, they put in your medical aid number. They can kind of, you know, have an idea of, you know, they'll speak to Discovery. Discovery will say, yes, this patient is under this scheme. We can authorize for this. We need all of those systems firstly. So they need a good patient registration system. They need a good health information system so that everyone, whether you go to Barra Hospital, whether you are in Shawelo Clinic, they will know that you are you and this is the issues that you have. So those are that's from just a health information system point of view. Then there's going to be payment systems, billing systems, HR systems that need to come into play in order to make the fund, you know, workable. And like I said, then they're going to have to think about, you know, how do from a facility point of view, because they will be working very differently to now, where they get a budget and then they use it to employ X many healthcare workers and buy X many Panados, etc. They're going to have to think about, okay, so what's our income stream like? Because now you get paid, you know, on the patients that you actually see. You won't just get a budget and then you figure out what to do with it. So then they're going to have to do some thinking around, okay, so how much do I buy? How far in advance? You know, all of that type of business functions, they'll have to start thinking about. So there's a lot of logistics in place that that they will need to test, and they are. they've started at primary healthcare level. They've got pilot sites, and they are testing out, in lifetime what those systems will look like.
Okay, this is in implementation. What are we looking at in terms of maintenance? What can they consider as a plan in terms of, okay, we've established this, maybe the systems have been built, how do we maintain what has now been built? What is there for them to think of there in terms of implementing this NHI?
So I think it also goes back to how the system changes. So for example, right now, money comes back to that pot, right? So that pot of money goes to, the national equitable share, and then the provinces get their money, and the National Department of Health gets their money, and then the provinces then decide, okay, so we're going to give X amount to healthcare, and then the hospitals get X amount of money, and the facilities get X amount of money. And you're changing that system now, right? You're changing where the fund will give those facilities directly their money. It's not going to come through provinces, for example. So there's also this discussion around what is the role of the province then. And there still is some role, because a lot of, for example, population health happens, at the provincial level. So like outbreak detection, etc., happens, in that level. So there is a role for the province to keep people healthy. But I think where the sticking point and why I'm explaining all of this is going to be, how do all of these articulate together now?
And at this point, I want to share this story, because we have one of our viewers that actually shared an experience which speaks about this surrounding infrastructure and response time. They shared that a few months back in rush hour on Oxford Road in Rosebank, Johannesburg. A young security guard was knocked over by a car at a traffic light, and she broke her leg. The police and ambulance were called immediately. Plus minus 3 hours later, neither the ambulance nor the police had turned up. Eventually, a passerby and the driver of the vehicle carried the lady into the back of the car and drove 3 kilometers to Charlotte Maxeke, where she was attended to. So if this can happen in Johannesburg, what are we really expecting? What are we expecting when it comes to the surrounding, systems and infrastructure to support the NHI in implementing what it wants to?
So that's an excellent point, because within public health and health, we are cognizant of what we call the social determinants of health. Health is not just what you eat and your DNA. There is a broader ecosystem around you. So whether it is education levels, how much you understand about healthcare, whether it is your employment levels, whether you have money to go and seek healthcare, whether it is the pollution outside, what the food system is like, do you have access to food, is there healthy food, etc. All of that plays a role in healthcare. And again, to the point that the NHI is, and I don't want to minimize the NHI's role, but they are the fund is basically just making sure you get services. All of these other things are the role of many, many more stakeholders. And we as the health sector have to ensure that we are engaging all the time with these stakeholders so that they understand the impacts of what they do on health. So engaging with the mining sector so that they understand, TB rates or lung cancer rates, etc. Engaging with agriculture to make sure that people have access to good quality food. With local municipality to make sure that the roads are, well tarred and, or people don't get assaulted because there's no lights, for example. So the point around the ambulances, that's run currently by the provincial health system. So how do you ensure that the provincial health system is well resourced enough that they have ambulances to, firstly, person shouldn't have gotten knocked over, because we should have good infrastructure for pedestrians to be safe. But if that happens, how do you end up getting them to the health facility? So all of this is health is everyone's business. the health sector can, yes, try and detect early and make sure people are treated, but really it's what everyone else does that has an impact on health. Recently, about a month ago, I was at a conference on urban health, and what was fascinating was at that conference they had, for example, urban planners, architects, all coming to understand how what they do influences health. So, for example, if you're planning a town, making bicycle lanes, pedestrian lanes, so that people are safe when they walk, but also that they can walk and stay healthy. So there's a lot of work to be done with all of these stakeholders to make sure that whatever policy, and we call it health in all policies, whatever policy is put in play, the consideration not just on, and economics is usually the one that we default on, but health. If I'm going to build this factory, what happens with the surrounding community? Are they exposed to anything, etc.? So that is a lot of the work that needs to be done. Again, like I said, NHI may not necessarily be responsible for that, but certainly they have a role to play in ensuring that we have the data, etc., that will show us patterns that we maybe need to investigate and use to optimize the health of our population.
Sure, Atiya, this has been really informative. But before we close it off, I want to maybe step into a dreaming state. And I really invite you to do that as well at home, because it can be so overwhelming to hear everything that still needs to be done and all of the issues that still need to be tackled. But in the ideal South African world, if NHI were to be implemented successfully across the board with the phased approaches, what reality could the South African citizen be living with the realization of NHI and all these supporting policies and bodies that have to come together for it to work, do the work, and it actually works? What does that look like?
So in a scenario where we get it right and we achieve equity for everyone, me in Johannesburg and Gogo in northern KwaZulu-Natal will both be able to access care quickly. So it should be around us. We shouldn't have to travel far distances to go there. It should be free at the point of care. So yes, maybe I might have to pay for transport, that's a reality. But it shouldn't be transport that's prohibitive. It should be something that maybe I can afford. It should be free when I get there. And whether I'm in Johannesburg or she's in northern KwaZulu-Natal, we get the same quality of care. We are seen, if I'm there for a diabetic appointment and I'm seen by a nurse, she would have a similar engagement with the health system in a way that we do not have to wait for hours. If I need blood tests, I can have access to them. If I need to be referred to a hospital, there's transport to take me. I get to the hospital, has good infrastructure, staff are well rested, they are not overburdened, they are able to respond to my needs, and I am treated as well as I can possibly ask for. The real, if we NHI aside, the real utopia was that no one gets sick in any case. And that is, again, to go to the point, we all work together to make sure people are as healthy as possible. But of course we cannot control either human behavior or genetics, etc. So people will get sick, and so when they do get sick, we all have equal opportunity for health.
And would that not be the fulfillment of our Section 27
right most definitely
to healthcare? Atiya, thank you so much for the time. I really appreciate, as a citizen, just as a regular South African citizen, to learn about everything that you've shared today. There's a lot that we don't know. there's a lot that we don't know, and there's a lot that we appreciate about people who do the work that you do, who can ensure that our government structures and everyone who provides for citizens can have the advice and the guidance to do so in a really impactful way. So thank you.
Thank you so much. I have to say thank you for creating the space. I think this is one of many conversations.
Yes, absolutely.
Because as you've heard from me, there are no answers right now. There is theory behind it. There's going to be a lot of practical testing. And so we need citizens to engage as that happens. Whether it is just learning, people will maybe be part of pilot sites. We need them to go and say, no, this is not working for me. This is difficult.
Do we hear this?
We need active citizenship. We
Absolutely.
need people to say, yeah, no, that was a terrible decision. This is not working for me. How can we adjust? And if we are going to get it right, we're going to need everyone across all levels of society, not just people sitting up in the National Department of Health who are responsible for tasking, with this task. And so I'm very glad for this space, and I hope that it is just the beginning of many, many conversations to come.
Absolutely. Thank you.
Pleasure.